Welcome to this podcast from Neurogastroenterology and Motility. It publishes original research and topical reviews on basic and clinical aspects of gastrointestinal sensation and motility, as well as brain-gut interactions. It is the official journal of the American Neurogastroenterology and Motility Society and the European Society of Neurogastroenterology and Motility.
So welcome everyone to this month's podcast from Neurogastroenterology and Motility. My name's Adam Farmer, I'm a gastroenterologist at the Wingate Institute in London, and it's my great pleasure this month to welcome both Professor Robin Spiller and Dr. Luca Marciani. Robin's a Professor of Gastroenterology at the Digestive Diseases Centre in Nottingham, and his main interests are around the pathophysiology of post-infectious irritable bowel syndrome, and more recently concerning the MRI assessment of colonic function. Luca is an Associate Professor in Gastrointestinal MRI, also at the Nottingham Digestive Diseases Centre, and his interests lie around the in-body imaging of foods, intestinal fluid fluxes, the gastrocolonic response to feeding, and the development of novel MRI tests to interrogate gastrointestinal function. Robin and Luca, welcome to today's podcast, and many congratulations on your paper entitled The Effect of Experimental Stress on the Small Bowel and Colon in Healthy Humans. So Robin, perhaps we could start with you. Could you give me some background to the role of stress in irritable bowel syndrome?
Yes, well, thanks for having us on the podcast. We all know from clinical experience that IBS patients are more anxious and they perceive their stressors as greater than normal. And they often report that stress aggravates symptoms, particularly diarrhea. But actually confirming that this is objectively true has proved quite difficult. There is work where people have recorded diaries of symptoms and stress, and there is a weak link there. I guess more recently we've had some fairly dramatic demonstrations with war veterans and post-traumatic stress, and experience in Afghanistan and Vietnam shows that this is a precipitant of a risk factor for developing IBS. And then we know that experimentally with psychological stressors you can change GI function, you can accelerate small bowel and colonic transit. And then in the more extreme situations, we know that if people are critically ill, for example, gastric emptying is also altered. So there's plenty of evidence to suggest that stress does interact with the GI tract.
So Luca, how really do you think MRI has facilitated an increase in our knowledge of GI motility, and particularly perhaps more recently in papers that you've published around in patients with functional GI disorders?
Well, the fabulous aspect of MRI is that it's non-invasive. So some of the old techniques use the ionizing radiation or intubation, which can be arduous for the patients and stressful themselves, and so they can bias a bit your measurements. While with MRI, one of the nice aspects of MRI is that the measurements are easy and non-invasive, and the look that we can have with dynamic serial imaging into the gastrointestinal function is spectacular these days. In the past, the resolution and the speed were not so good, so MRI gastrointestinal function lagged behind other districts of the body, like brain imaging. But now has developed and is starting providing novel insights into function and motility and transit.
So, Robin, back to you. Really, today, what have the animal studies shown us concerning the role of stress in modulating sensory motor function within the GI tract?
Well, as we alluded to already, showing the effects of stress in humans is actually quite difficult, mainly because of ethical constraints. So we no longer consider it reasonable to subject people to fearful stimuli or physical damage. But of course, much clearer results have been obtained with animals, and we've got a number of models of psychological stress in animals, including water avoidance, maternal deprivation, and social confrontation, all of which are non-injurious but do stress the animals. And you can show that colonic transit is accelerated, that gastric emptying is delayed, and critically for this study, the role of corticotrophic releasing factor has been shown because if you block CRF, you can inhibit nearly all these effects, and you can reproduce them by giving exogenous CRF.
So, Luca, then that brings us nicely to what were the hypothesis and the aims of the study that you've undertaken.
So maybe I could take that, Adam,
okay.
Because I mean, we'd already done some studies with IBS patients and MRI, and we showed that the bowel was constricted. And we knew from previous work by others in Japan that IBS patients were hypersensitive to CRF. So really the idea was to see whether we could reproduce the abnormalities we had found already in IBS in healthy volunteers using the CRF. And we used two stress models. The CRF was obviously an injection, but we also wanted to use the ice-water hand immersion model, because other people have used this. It does stress people. It puts up your blood pressure and pulse and activates the hypothalamic pituitary axis. So we thought that it would be interesting to compare these two rather different stressors.
And so what were your key results from your study?
Okay, so the main observation we made was that we could indeed reproduce the abnormalities that we had previously reported in IBS patients. So the paper we published in 2010 described for the first time the spaghetti bowel, that is the constricted small bowel with reduced volume. And perhaps I should mention that I regard this as one of the real strengths of MRI, is that we can interrogate the whole small intestine. Our previous work generally only gave us information about small segments. I can remember doing lots of perfusion and manometry studies, and we were trying to infer from a study of 30 centimeters what's happening in the whole small bowel, which of course is 10 times as large. So we showed that the CRF constricted the small bowel. Ice stress also did, but not quite so clearly, and there are probably good reasons why that is the case. And along with this constriction of the small bowel, we observed an increase in the ascending colon volume. And our interpretation of that is that increasing the tone in the small bowel will make fluid go through the small bowel quicker and enter the colon. Now, the other really important finding, and we weren't expecting this, but it was a really interesting finding, and that is we could induce the sensation of bloating in healthy volunteers by giving CRF. So they felt that their guts were more dilated, despite the fact they were actually constricted. And I think this makes it clear that this rather mysterious symptom that patients so often complain about is probably a reflection of increased tone rather than necessarily an increased volume of any particular organ.
So what do you think then the clinical implications then are these findings, particularly relating it back to the previous work that your group's published?
Well, I think we should be a little careful in extrapolating to patients. But I think what it does suggest is that if you've got increased tone by whatever mechanism, and it might be CRF, but it could also be an autonomic response, increased sympathetic tone perhaps, then we could expect faster transit through the small bowel, more fluid in the ascending colon, and this could contribute to the symptoms of diarrhea. And of course we do see patients who get diarrhea on Monday morning when they're going to work, but not on Saturday when they're relaxing, so that certainly might be a contributor. The other important thing, I think, is that if stress does increase tone, then it could explain the bloating sensation, and which I've always found mystifying, really, because the patients can get bloating after a meal, but they can also get up in the morning and then suddenly get it, and that has to be some sort of neurological response, and increased tone in the small bowel just might be that mechanism. I've put a caveat on this because I do think we need to recognize that CRF1 antagonists have not really been shown to be effective in IBS. And so it may well be that it almost certainly is true that there's more than one mechanism for the symptoms in the patients. But you have to simplify things to study them and get clear answers. And I think in healthy volunteers, the CRF is quite a useful model.
So, Luca, how do you foresee the technology of gastrointestinal MRI developing in the future? It seems like a really exciting technological advance, and one that seems very patient friendly. But what do you see the developments for routine clinical practice maybe in the next 10 to 20 years?
It is very exciting. For the study, we have used a couple of MRI imaging sequences which are very common and familiar to all the clinicians, the MRCP, the magnetic resonance cholangiopancreatography, just to look at water, and some volume dual echo sequence that is used to look at liver, for example. But one of the limitations in our study was that we haven't used the transit and the motility techniques which we are now developing, and we think will be the future, absolutely. In the past, some of the techniques were only selected and limited for some research laboratories, so they were not available to the clinical practice. But some of the MRI parameters which we have used in the study, and the ones we would like to have used, like motility and transit, are actually now be able to be performed in a single short scanning session, say 10-15 minutes. And they can be applied to any scanner worldwide in any hospital. So translation is a real possibility, and is one of the focuses of our work is to try and translate these exams into something that can be used by any clinician everywhere in the world.
And if I could add to that, I mean, I do think that the volume measurements and the transit measurements are very valuable, but equally, I think one of the things that we're hoping to develop, and we are actively developing, is actually cine imaging of the bowel, looking at contractions, because I think this also could be very helpful, particularly in people with constipation, where you can't really sort out what is the real underlying problem. Is it a behavioural problem? Is it really a problem with motility, which we kind of assume? To be able to measure it, I think, would be a big advance.
So with that, I'd like to thank you both for your excellent paper and assisting with this month's podcast. I'd also like to thank our listeners for tuning in, and I look forward to welcoming you again next month on another instalment.
Further information about this paper can be found on the journal website. We hope that you have enjoyed this podcast, and we look forward to welcoming you to next month's edition.